Full house today down here. It's good to have everybody here. Thanks for coming to support Andrew. I'll just real quickly say these events are always a little bit bittersweet because those of you who know our lab and our history, we've been fortunate enough to have some really, really good PhD students come through, and so we're always kind of sorry to see them finish and leave and move on because we want to keep them. But at this point, you know, we're also anxious and happy for Andrew to move on to the next step. I'll just say the thing I normally say, which is I can say truly Andrew deserves to be at this phase. This step in a PhD, getting to the point where you're defending your dissertation, kind of is in some ways the only step that counts. All the stuff you do prior to that is necessary, but this is the one that counts, and he deserves to be at this phase. I want to also say, as we came out of COVID, our work with Straub Hospital, Straub Bone and Joint Center with Dr. Nakasone had kind of gotten slowed down a lot by COVID. UH wasn't allowing us to collect, Straub wasn't allowing us to collect, and the lab was dark and nothing was happening even as we came out of COVID. And Andrew came in as a PhD student with some ideas that really fit with what we were already doing. It kind of was very complementary to what we've been doing for over 10 years with Straub. And he pursued grant funding from the Far West Athletic Trainers Association his first year and got this study funded. And then we spent the next 2 years collecting these data, and really he has kind of pioneered something that we weren't already doing. And so he deserves a lot of kudos for kind of taking a next step for our lab with things that we will continue to do, because as much as he's going to present to you in a minute, this is probably 40% maybe only of the data that we collected as part of this study. So we still have a lot of data to churn through. So without further ado, take it away, Andrew.
Thank you very much, Dr. Stickley, and thank you for everyone that's here today and then tuning in on Zoom. So let's just jump straight into it. There's a lot to cover, and Dr. Stickley has me on a strict time limit, so we're going to try to blaze through all of this as much as possible. And I'm going to talk about what we've been doing in our lab and my dissertation, which is the effect of anterior cruciate ligament reconstruction on long-term post-traumatic knee osteoarthritis risk due to persistent biomechanical loading alterations. So I want to start by, when I was thinking how to present this, there was a vivid memory that came to mind, and this was when I was a master's student here in the program at UH, the athletic training program. And I remember my dad asking me one day, I don't even know who we were talking about, but an athlete had an ACL surgery. And he asked me, are they going to return back to play? And me being a master's level student, I didn't know anything that I didn't know. I told him, I think they'll be fine. They're gonna get ACL reconstruction. Typically the graft that we put in your knee is way stronger than your native ACL. You go through recovery and strength and conditioning, and you should be well back on the field and performing at the level that you did. That is partly true, but I think back then, I only looked at ACL reconstruction as a mechanical kind of approach to restore their knee function. And that's what I want to dive into today, is kind of explaining more of the intricacies and nuances of why your ACL is so much more than a mechanical constraint. So to give a little backstory, kind of leading up how we even came up with this idea, through my career, I was fortunate to work in a lot of different settings outside of your traditional athletic training environment, where I got exposed to a lot of different athletes. I wouldn't even say in sports, like across life. And I saw a lot of ACL injuries at the college level, the professional level, and when I was directing a clinic, I saw a lot of people at different life stages recovering from an ACL injury. So people, of course, that just tore their ACL before surgery, all throughout the rehab and recovery phase, strength and conditioning, and even beyond that. I got to see what they look like 10, 15, 20 years after. I saw people that were doing very, very well, no issues. And I also saw people that 20 years later, they were experiencing signs and symptoms of knee osteoarthritis. So it kind of gave me this different lens. And I also got to see the aftermath of even people that didn't sustain ACL injuries after, when they're in their 60s or 70s, just dealing with this debilitating disease of osteoarthritis. So that's kind of what sparked, how can we address some of these issues that happen, the long-term issues after you sustain an ACL injury? How can we better improve the outcomes so that they don't go down this debilitating path? Also, when I remember too, when I first started the program, even through the application process when I was talking with Dr. Stickley, there was one thing that really stuck out to me, and I don't know if he was just saying this to just keep me interested, but he was like, we really want to study knee biomechanics across the lifespan. And he was like, I know we do a lot of osteoarthritis and total joint replacement knee research, but we're really interested in the younger population too. Him knowing that I like rehabilitation, strength and conditioning. So it was just something that stuck in the back of my mind. There has to be something that we can look at biomechanics related that will explain why some of these people are getting, as you'll see in my presentation, post-traumatic osteoarthritis. So let's start with kind of what osteoarthritis is. And I think this is important. A lot of us here are athletic trainers or strength coaches, and I think we underestimate how debilitating osteoarthritis is. So osteoarthritis, it is when you have extreme inflammation and chronic articular cartilage degeneration, and your knee is undergoing a lot of physical pain, a lot of loss of function. But beyond that, it's a very debilitating joint disease. And it's one of the biggest or leading disabilities worldwide, actually, dealing with osteoarthritis. And what we see is that it goes well beyond just your knee at that point. It starts to affect every aspect of your life. So physically, mentally, associated with psychological distress. It's linked and associated with a lot of other chronic diseases. So it's going to start to really take a toll on your overall life. It's definitely life-changing for sure. Now, once you get to end-stage osteoarthritis, where it's very severe and you're having trouble just dealing with activities of daily living, what happens is we don't really have a cure for this disease. So the best treatment option is that we do some carpentry work in your knee and we give you a total knee replacement or total knee arthroplasty. And what we see across the literature in research, but also when we talk to Dr. Nakasone, this is pretty accurate that we have a pretty good success rate. But if you were to ask patients if they're satisfied with their total joint replacement, for the knee especially, the satisfaction rate is only around 80%. So think about that. Think about anyone that you know with osteoarthritis or who had a total joint replacement. Think about how they're moving around, their quality of life, how this is impacting them well beyond just the function of their knee. So it is a big problem. And what I want to emphasize here is that this is something that happens when you're typically like 60 or 70 years old. It's something that happens later on in life. So what I'm going to do is try to connect some of the dots, because when we talk about post-traumatic osteoarthritis, people around my age are starting to exhibit these signs and symptoms, which is definitely going to be life-changing. Last thing too, before I move on, is that we constantly see or hear or joke with our athletes even, oh, you know, I had all these injuries, I'm going to get osteoarthritis. The one thing that I want to emphasize today is that even though it's, you know, made in light of, right, I don't think any of them have the foresight or fully understand what osteoarthritis is like. And even though they're just kind of accepting like this is my fate or this is my path, it's definitely going to be life-changing for sure, where I'm pretty sure if you ask anyone with PTOA today, if they could have done anything to kind of mitigate some of that risk or lengthen out that progression of OA development, they probably would have said, yeah, let me know what I need to do, because it's that debilitating. So let's get into, I'm going to spend a good chunk of time going over this theoretical framework that we've discussed a lot, but to just give some background so that when I get to my results of my dissertation, it makes a little bit more sense as to what we're finding and how that relates into real-world application. So the theoretical framework, let's backtrack a little bit, and let's start with ACL injuries. ACL injuries, I want everyone to think about someone that they know right now. Maybe someone recently suffered an ACL injury, or whoever you worked with or friends, family that had an ACL injury. Try a picture them as I discuss kind of this timeline and the outlook for them. So ACL injuries, it's surprisingly not as uncommon as we would like. Basically, this stat is a little outdated, but it's probably a little bit more right now, but annually in the US alone, there's about 250,000 ACL injuries and over 2 million worldwide. A lot of these ACL injuries are sustained by young high school and college athletes. Keep that in mind, because the time frame and chronological sequencing of events that occurs, that's the thing that's really concerning. What happens is many times literature even supports this, is that about even upwards to 70% of these ACL injuries, even if they're in a contact or collision sport, they're sustained by non-contact or indirect contact mechanisms. So 70% of them, and think about this, as the athletes go through jumping, pivoting, cutting, they may have done that thousands and thousands of times, but for some reason at that point in time, they tore their ACL. We don't tear our ACL, every time that we go out on the practice field or court. So what contributes to this? And emerging neuroscience literature and other aspects have shown that there is basic fundamental sensory motor coordination errors that pretty much put our knee in this unsafe position that excessively load our ACL and leads to an ACL rupture or tear. So moving along, I'm not going to spend too much time in the rehab phase or the strength and conditioning phase, but more long term, what happens is that once you sustain an ACL injury, you're 3 to 6 times more likely to develop knee osteoarthritis. So that the odds are against you at that point, just from sustaining this injury. About 50% of these patients will develop osteoarthritis within 10 to 20 years after their ACL injury or surgery, which I'll talk about in a second. And what this is termed, this is a subcategory of OA because it's become so prevalent, termed post-traumatic osteoarthritis, or you're going to hear me say repeatedly in this presentation, PTOA. So it's those that have sustained a traumatic joint injury. This is the type of osteoarthritis that they get, this accelerated path to cartilage degeneration. So after they sustain these injuries, typically to return back to any type of more explosive or intensive sport, we opt for ACL reconstruction. And with modern surgical techniques, it has come a long way. I think we're getting a lot of people back to sports and being active again, but it's still not a perfect procedure that is being done. So what I mean by that is we really focus, or the approach has been very mechanocentric, meaning that the primary goal of ACL reconstruction is to restore mechanical stability in the knee. And we learn about this in athletic training curriculum, strength and conditioning curriculum. But the fact is that, at least to my knowledge, I don't think we're anywhere close to restoring the neurosensory function of your knee. And this is going to be something that I'm going to unpack a little bit. So basically, your ACL has a lot of mechanoreceptors, sensory receptors in your knee that detect all of this fine-tuned, intricate knee motion. Even with the surgery and kind of everything that comes along with it with rehab and literature, there's been a lot of emphasis on return to play. There's been less emphasis on long-term knee health, even though we're trying to mitigate some of the adverse effects. But everything, if you think about rehab and what people usually go to, the primary goal is to get you back on the field or court. After they're done with competitive sports, they kind of fall off a little bit. They kind of drop off. You don't know exactly what happens to them, especially on this road to get PTOA. Me learning through, as a practitioner myself, but also through athletic training curriculum, I always thought, and I believe this even to the point of my first year in the PhD program as a student, I thought that if you get ACL reconstruction, you're mitigating the risk of developing PTOA. To my surprise, widely spread across the literature, and even if you talk to especially people that deal with osteoarthritis, physicians, practitioners, that is not really true. Our risk of getting PTOA is the same regardless if you get reconstruction surgery or not. So that's something to think about too. That was eye-opening for me. And then once you're down this path, once you get PTOA, you're 7 times more likely to require a total knee replacement. So again, think about that, because does this mean that all of these people that tear their ACLs in high school or college, are they going to get total knee replacements when they're late 30s or early 40s? Because again, this timeline is drastically shifted up. This is something that we see in people that are usually in their 60s, maybe 70s, if they're lucky and they're prolonging the knee replacement, but the timeline is the thing that's of concern. So what I want to mention here is that, again, this stat is kind of what sticks out. There's some give or take, some stats are a little higher, some are a little lower, but overall the average seems to be about 50% of patients will develop PTOA within 20 years after ACLR. So again, think of those people that people that tore their ACL. think if someone tore their ACL when they were a senior in college. And I'm gonna kind of put this into perspective, kind of dating myself a little bit, but this year actually is my 20th year high school reunion. So if I tore my ACL when I was in college, that means half of them are gonna experience, they're gonna be walking like your 60-year-old with osteoarthritis. Not gonna be able to play with their kids, not gonna be able to be mobile and active anymore, and they're down this path of, yeah, I'm probably gonna get a total knee replacement. And that's the thing that's concerning. 50% is pretty bad. You know, we gotta figure out how can we mitigate this problem, because again, returning to sports, that's important, but your long-term health is probably more important, especially when you get to this stage. So, backtracking a little bit, that's kind of the outlook even after surgery. What happens during the return to play phase? And I'm not gonna go too much into the sports function stuff. I'm gonna go or stay in the kind of realm of activities of daily living. Basically, we're not using our knee how we would normally use our knee. And that's the biggest problem that's probably affecting our knee health long term, and also, you know, the mechanics of articular cartilage degeneration. The first point here, this is getting into biomechanics now, but I want to give a little insight or background so that people know what we're talking about. What happens is when we're walking, one of the ways that we measure forces through your knee is what we call moments. So knee flexion moment or knee adduction moment, that's widely studied. And basically it's just a torque on your knee. Imagine if I had your leg and I was placing force to bend your knee into flexion, that's a knee flexion moment. In the frontal plane, if I had your leg and I tried to move your shin medially, that's your knee adduction moment. Now, someone's not physically doing that to you when you're walking, but the ground reaction force is forcing your knee in that way. So we're measuring how much torque is being placed around your knee joint. What we see, and this is very consistent across literature, is we're seeing that these people are walking with lower peak knee flexion moments and peak knee adduction moments. That means that they're not even walking normally yet, and this is when they're returning to play. This is like 1 to 3 years post-op. So if you think about that, we're having them do all of these things, but when they're walking around, the thousands of steps they're taking throughout the day, they're not loading their knee how they would load it normally. So that's the concern. This persists well beyond the return to play phase again. And again, I don't think this is due to lack of strength or lack of stability, because remember, the surgery, we're pretty good at restoring mechanical stability. Strength-wise, I would hope as practitioners we can restore basic strength to walk, right? We're not even talking about higher levels of activity. We're just talking about walking. So again, there has to be another reason as to why this persists. And what has been emerging with literature and neuroscience, and I know Dr. Dustin Grooms is on here as well, a lot of his literature has shown that there's persistent somatosensory dysfunction and neuroplastic changes that occur following the ACL injury or the surgery. That is probably why we're moving in different ways that is not normal, or we wouldn't move normally if we had all of that sensory feedback from our knee. So the next thing is what happens long term? And this is super interesting because there's not as much literature with long-term studies. And that's what sparked kind of our discussions and why we wanted to do this study. So I want to share this kind of model. So once you tear your ACL, what happens is that your ACL is a huge sensory organ in your knee. It houses all of these mechanoreceptors, sensory receptors that are signaling constantly afferent feedback, not with big gross movements, but we're talking about this fine-tuned kind of knee mechanics, because your knee is so intricate and the way that it moves as we're doing different types of loads or tasks, it's very precise how it needs to move. What happens is once that's disrupted, now we have this disruption in our sensory motor system. And these are fundamental sensory motor deficits, like how I mentioned with walking. Dr. Dustin Grooms, they've looked at even you doing like a leg extension. There's altered sensory motor patterns that's occurring because you don't have that sensory feedback from your knee. When you constantly do this long term, what happens is that our brain actually changes. That's what neuroplasticity is. So it changes not only in function of how you're processing this information, but also chemically, structurally, your brain actually is starting to change. And we see altered patterns of activation, altered strategies to create movement or control movement or sense movement. And this is what's contributing to some of the deficits or adaptations that we think is happening long term. And once that happens, basically your abnormal knee loading mechanics is driven or fueled by all of these sensory changes, neuroplastic brain changes, and it leads to this altered motor output. As I was thinking about how to relate this, because I know I'm just saying a lot of words, I thought of a good analogy that everyone can relate to. And I actually talked to my dentist about this because I rehabbed his ACL. And the more that we started talking about this, we're like, this is actually probably a good way to relate what I'm talking about here, what's going on with your knee, with something that everyone can relate to. So we all had dental work before. We all got numbed up in our mouth, right? And if you think about that, what they're actually doing is they're blocking your nerves, your superior and inferior alveolar nerves, which is purely sensory nerves in your mouth. It has no innervation to the muscles that involve chewing or mastication. We did nothing structurally to make your mouth unstable or affected your TMJ joint. We just blocked the sensory signals going back up to your brain. Every dentist will tell you, of course, avoid extreme temperatures because you can't feel, right? But they'll also tell you, try to avoid eating or chewing anything and stay to a soft and liquid diet until you get your sensation back, right? Because what is going to happen if you start to eat something? We've chewed food our entire life, every meal, right? We know how to chew. We didn't lose function or strength, but because we don't have that sensation, you are gonna bite up your lip and you're gonna be bleeding all over the place without even knowing. That's the fine-tuned motor control. We need sensory feedback to control this intricate movement. You can still chew the big movements, but you cannot control avoiding biting your mouth, right? And that's not normal. Because if I told you, how many of you guys bite your lip every time you eat something, right? If you do, you better go get your sensory system checked. But that's not normal, right? So take that same analogy of your knee, right? If you don't have that sensory feedback from your ACL, which is a primary sensory organ in your knee, you're losing this subtle control, this subtle loading. We're not talking about squatting or jumping. I'm talking about the subtle loading. It's like you're biting your lip every time you do that motion. My knee is moving in an improper way every time I take a step. So think about that. That's kind of the sensory influence of this abnormal motor output. So how is this contributing to PTOA? So that's what I want to connect some of the dots here. Basically, knee loading is directly modulating our articular cartilage health. So what happens is that our knee or articular cartilage, it is more dynamic than I thought initially. It needs mechanical stimuli to have this compression and decompression kind of force throughout the day, typically with cyclic and repetitive motions like walking, running, going up and down stairs. And that is what's creating a favorable adaptation or adaptation to create durable, healthy cartilage. And this is the same thing we see with bone or soft tissue, right? Wolff's Law or Davis's Law, whatever stressors we place on our tissues, it's going to adapt in that fashion. And what's happening is that your articular cartilage, based off of the mechanical stimuli that is placed on it, it has the ability to modify metabolism, nutrients, extracellular matrix components, and all of this is either going to keep our cartilage really healthy, or it's going to start to cause it to thin, weaken, and break down. Kind of like you're not using your cartilage how you should, we're going to have it break down. And just like as I was talking, over time, this happens very, very slowly. Your healthy knee turns into osteoarthritic knee. We're not talking about like 1 year later. We're talking about 10, 15, 20 years later because you're not giving it the adequate mechanical stimuli that it needs. And what is important to understand, and this goes with any tissue in the body, is that there's an optimal range for healthy loads. So overloading, as we see with osteoarthritis, that's problematic, obviously. Too much load, we're going to cause damage and breakdown in our articular cartilage. But what's happening, or the proposed theory right now, is that after ACL surgery, you are underloading your knee in an unhealthy range. And because you're not giving it the necessary stimuli, it's causing your articular cartilage to weaken, thin, and degenerate over the long term. So we're just outside of the optimal healthy mechanical stimulus. So evidence has shown that following ACLR, athletes are underloading the knee with walking. Running has been less studies, and going up and down stairs has even been less studies, but the majority agrees that we are underloading our knee during these activities because we don't have that sensory, well, they don't express that explicitly, I guess, but a lot of it has to do with the lack of sensory feedback to the brain, which is probably not able to detect how to normally load your knee joint. So we're seeing this. We're seeing that they're typically measuring decreased knee moments, and we're seeing this with walking especially, but like I said, running and stairs. And there's evidence that this is happening up to 5 years post-op, which is surprising, because think about this. Even like when we get athletes through the rehab process, we're making them run anywhere between 12 and 16 weeks. These guys can't even walk right at 5 years post-op. So there is some fundamental sensory motor deficits or some type of alteration that's causing them not to want to load their knee how they would normally load it. So that's surprising that it's lasting so long with such a low level activity. Now, why does this have significant implications? Is because when we talk about every step, if you're underloading your knee and you take about maybe 3,000 to 5,000 steps on that one leg alone, and you do this for years and years at a time, that's the idea of cumulative loading. This small change with every step, that is going to add up and compound as the years and decades go on. And when you do that, I mean, if you think about it, if you worked one arm more than the others for 10 years, right, it's going to compound itself, and you're going to have different types of adaptations on the side that you're doing more and the side that you're doing less, right? So that's kind of what we're seeing. And over the long term, what happens is that we see, again, all of the adverse effects that we don't want to see in articular cartilage. Basically, it's weakening, thinning, and degenerating. And this, again, happens over the long term, like 10 to 20 years. So how does this actually lead into PTOA, and what does that look like? So through our discussions of PTOA, Dr. Stickley and I have come up with this model, and I still think, even as discussions develop and I read more things, I think this model is a pretty accurate representation. We don't know exactly what this curve looks like, but I'm just gonna break this down really quickly. So on the y-axis on the left side, you see activity intensity. Basically, we're just saying whatever you're doing throughout the day, right, sport activities or ADLs, this is kind of the loads that you're placing on your knee joint. On the right side is representing cartilage health with that yellow line that's going on a downward slope, right? We're representing what happens to articular cartilage health as we get further and further out from ACL surgery. So what we're showing here is that red line, that top solid red line, represents like sport demands. Like, what do you need to entail? How does your knee respond to sports intensity? What we think happens is that once you tear your ACL, you've been loading your knee normally, you've been using it properly, your articular cartilage is most likely very durable at the time of injury. And you can see that the yellow line starts on that 0 time frame of years post ACLR. It starts above that durability, or what is needed to tolerate demands of sport. What happens is, as you start to unload that for about 5 years, right? If you look at the 5 year mark, that's kind of where that yellow line intersects the sports intensity line. And we think that around that time, if you've been underloading your cartilage, we could be potentially weakening our cartilage to the point where that sport intensity activities, that might be becoming a little problematic. Meaning that, what does this look like in real life? Those are your guys that are still playing recreational or semi-competitive sports, and they're experiencing knee pain. Maybe their knee swells after activity. Maybe it's starting to become more problematic. They can't do the duration or the frequency of their sport because their knee health or their articular cartilage is declining. If we continue to underload our knee, right, for about 10 years, now we're right in between the sport intensity and the ADLs, activities of daily living intensity. When you continue to underload your knee and your cartilage health gets weaker and thins and degenerates, around that 15-year mark, we have that slope for cartilage health intersecting your activities of daily living. So how you responded to sports at around 5 years where it aches and you can't do all of the things that you want to do, you have limitations, you're starting to get that with activities of daily living. Walking, going up and down stairs, running errands, right? You might not be able to tolerate that because your articular cartilage is not strong enough anymore. And that's where, from 15 years on, that's those people that potentially get PTOA. Their knee is so degraded at that point, they are functioning like a 60-year-old knee that has OA developed by natural means, right? So this is kind of the model that we've developed. And to just reiterate, why does this underloading persist? And I want to go back to this chart. Again, I don't think it's purely physical strength or mechanical instability that's causing this underloading or degeneration. I think there's a big influence with some of the sensory or sensory motor functions and applicability to kind of drive some of these cellular changes that we're seeing with PTOA. I did want to make a mention, because what I've been talking about is that we have a disruption in our ACL and sensory organs in our knee, and then up the chain, the afferent signals are, for lack of a better term, dysfunctional, and then we get these brain changes, and then it affects our motor output. What's super interesting, and I know Kumiko's on this call too, I think she works with some of these authors there. There was a study done with NFL retired players with a history of concussion, and one of the key findings was that they found that retired NFL players with one or more concussions during their career, and regardless if they had a history of traumatic joint injury or not, they reported a higher prevalence of osteoarthritis. And this was well after they were done playing. But this is the same kind of loop that I'm talking about. You have damage to your brain or some dysfunction in your brain, but again, they're all related. So it's modulating joint loading in some way that maybe that's contributing to knee osteoarthritis. So again, it points to that there's more than just the mechanical output. There's something that influences abnormal mechanical output that's driving some of this. Okay, so I know that was a bunch of time, but that's the theoretical framework. And now I want to get into my dissertation and some of the findings. So this is our lab, right behind us. This is our lab where we collected all the data. And what I wanted to look at for my dissertation, and a portion of the data, is basically looking at what are the persistent biomechanical loading deficits or alterations that's happening during walking and running, and how do some of these connect the dots from ACL reconstruction surgery to developing post-traumatic knee osteoarthritis. So I want to share a little bit about the approach, because I think this is what's making the data very interesting, and I think that's going to shed a lot of light as to what we're seeing long-term happening. So there were three aspects that I really wanted to target with my dissertation. One, the long-term time frame. Two, how are we quantifying or analyzing loading mechanics. And three, task intensity. Activities of daily living, but basically at a tiered kind of system with tasks. So let's go over the first one, long-term. What you see in the literature is that we have a lot of return to play studies. Of course, the performance metrics, jumping, side cutting, sprinting, all of those types of things. There are some gait studies, but again, it's not as much as you would think when we get further along this time frame. So typically there's a lot of research in that 2 to 3 year mark. When you get to like 4 or 5 years, it gets pretty sparse. And then on the back end of this, there are very few studies looking at PTOA around 20 years out. You're starting to look into OA literature. There's a huge gap. We know that ACL injuries and PTOA are related. We know that you're gonna get it in a faster sped up timeline or accelerated time frame. But there's very little studies happening between this 10 to 20 year mark, where we probably need to understand how are they moving the most. So that's where we wanted to try to sit in that space. The second thing is loading. Okay, I have to make this chart because our early conversations with Dr. Stickley and I, it gets so complex and confusing so fast, we didn't even know what comparisons we were talking about. I actually have it written on the whiteboard too, so people can refer to this. What we did was, we called the ACL reconstruction limb, we called that the ACL limb. You can see that the ACL subject is this horizontal category right here, or section right here. So ACL limb is the ACL limb. Their healthy limb is the contralateral limb, which I call contra. Then, for the healthy control subject, we call the matched ACL limb. So basically we matched the limbs by leg dominance, and we took one of the healthy control limbs and matched it to the ACL limb for comparison. And then we took the other control limb and matched it to the healthy limb of the ACL person. So I call these matched and contra matched. So if you ever hear matched in the abbreviation, we're talking about the healthy control person. If there's no matched, we're talking about the ACL subject. So this is typically what happens in literature. I was surprised actually. Majority of the literature only makes, I shouldn't say, between a ACL person and a healthy control person, they're just concerned in reporting the values between the ACL limb and the matched limb, so just one side. Very few studies look at the opposite leg, which I think is important because we need to know how are they moving, because there might be a compensatory mechanism there. So I looked at the contra and contra matched legs. And then lastly, I looked at the interlimb kind of comparison between the ACL and the contra leg. So those are the things that I'm going to talk about as I go through the results. The second thing was, this is going to be a little short refresher of graduate level biomechanics to get everyone to understand what we're looking at. So we wanted to create a comprehensive loading profile beyond just peak values. So what I mean by that is that this is a typical knee adduction moment graph. We look at tons of graphs during walking. Most people have this bimodal hump, and this is what the curve looks like. What majority of the literature is reporting is this peak value. So where that dot is, they'll take everyone's peak value and compare that across groups or across limbs. But again, we're saying that that is the most important value that we should pay attention to over this entire loading phase of stance, which there's pros and cons to that. So then you can say, well, let's look at more in-depth or more detailed variables, complex variables. And then we start to look at something like the average rate to that peak force. So what we're doing here is that we're just taking the magnitude across how long it takes to get there. We get a simple slope, and this represents the average rate of this moment, so moment rate. But again, you can see there's one problem here. We're still only looking at, this usually occurs in the first 30% of stance or so. So we're still neglecting the rest of stance phase. I mean, this is kind of like if you were watching a sports game and saying, well, only the first quarter matters. We don't have to play the rest of the game, right? There's a lot of other things that might be pertinent to what we want to know that's happening later on in stance. So we need to kind of figure out how to expand that and start to look at the entirety of stance, because that's all important to this whole theoretical model of how we're loading our knee. So then we look at these variables, and we're starting to get into the nitty-gritty. But basically we can look at, we're taking the integral of this curve. And this area, the area underneath the curve, it represents the total exposure to this variable. So total exposure to frontal plane knee moments or knee forces. So now we can quantify that. That might get us a little closer to figure out, okay, what types of loading deficits or alterations are there? And then the last thing that has been more, I guess, new in the biomechanics literature in the last like 5 to 7 years or so, is that we can actually analyze the entire waveform. And this gets a lot more complex. I'm not going to explain the details of it, but basically we're going to analyze if there's different regions of this entire waveform with statistical analysis to see, is it more than just one point in time that's different, or are they doing things through a phase of stance that's different? Now there's some complexity with this, because I want to just show this because I think this is an interesting point. This is actually all of the healthy control knee adduction moment in my study. So you can see everyone has this bimodal hump, but there's some variance there. How we actually average or take a group mean of all these waveforms is at every single time point in stance, this 100% of stance, we take an average. Now I want to kind of flip back and forth, because we lose some information when we start to analyze waveforms, because as I flip back and forth, that is the group average. I lost the magnitudes, the peak, the shape is relatively representative, but it's distorted as far as magnitude. Timing might be a little off, right? Because you can see that even though that's the group average, it might be hard to detect things, especially with a normal task like walking or running, between an ACL person who's moving normally and a healthy control person that's moving normally. I just wanted to put that out there because it's giving you some insight as to, we're looking at variables that are, we call them like higher order variables that are containing a lot more context and information and giving us some of the nuance of loading. So anyway, that's the little spiel about loading. And the last thing is that we wanted to look at varying intensity of tasks. Walking being the most simple. We do stair negotiation research here. It's not part of my dissertation, but we've kind of come to conclude that complexity and as far as intensity on knee loading, going upstairs and running, they actually show very similar trends. And then the last thing is that we do stair descent research as well, which again won't be included in my dissertation, but we have a variety of tasks that we wanted to look at. Okay, we're almost there. I know Dr. Stickley has a running timer on me, so subjects, or let's go over the methods. So basically subjects, we collected ages between 18 and 45 years old. We collected ACL subjects who were more than 2 years post-ACLR, and we also collected healthy controls. I know this is a little small, but basically there were no differences between groups for demographics or anthropometrics. What's super interesting is that our time frame post-ACLR is actually at 8.2 years or so. So we're looking at well beyond return to play. The one thing that I want to kind of make mention of, and the graduate students that helped with data collection can attest to this, is that these ACL subjects, they were very high functioning. We had a bunch of former college athletes, a handful of professional athletes, people who are very active to this day, still competing recreationally. Some are still competing professionally. So there was it was very a high functioning group. So the fact that they're 8.2 years post-op and very high functioning, just keep that in mind when we talk about some of the results, because to me, it was very counterintuitive that we found some of these loading deficits in people that are functioning at such a high level. The other thing too is that I stand by this. I don't think anybody, even if you're very good at qualitative data analysis, with some of the things we found, if you watched our data collection, you wouldn't be able to tell who's an ACL subject and who's a healthy control subject. They are moving that normally with walking, running, and going up and down stairs. So just something to think about. Okay, so study design, cross-sectional study design, no follow-ups or anything. And again, comparing the ACL group to the healthy control group. We did walking, running, and stair negotiation, but stair negotiation, we won't talk about it in this dissertation. That will be saved for a later date. I did want to just make a mention of this because my whole interest was that somatosensory kind of dysfunction and influence. We actually did test them doing these tasks with the strobe glasses on and without the strobe glasses on. The whole premise is that if it is sensory related, if I start to take away and disrupt more sensory input, how are you going to tolerate and affect how you're controlling movement? So again, we did not include any of this in this dissertation, but it will be analyzed more in the future. All right, data collection. Everything was collected here with our full biomechanics setup. So 3D motion capture and kinematics with the force plate, or kinetics with the force plate embedded in the ground. And our statistical analysis, we wanted to create as comprehensive of a loading profile as possible. I do want to cover this tiered approach that we decided to go with. We understand that there's some inherent differences between males and females in all of these tasks. So we wanted to make sure that females and males were responding similarly before we grouped them as an ACL group and a healthy control group. So we did this procedure where first we ran a two-way full factorial ANOVA, comparing any interactions between groups, so ACL people and healthy control people, and sex, males and females. If there was an interaction, we analyzed males and females separately. If there wasn't an interaction, we collapsed or combined the males and females, and we analyzed the groups as group comparisons with independent or dependent t-tests. And then if we found any of those significant findings, then what we did was we used statistical parametric mapping, or comparing the actual waveforms. We used that to see if there was anything that could further explain what's creating some of these differences. So that's what we did. So let's get into, and I'm going to give the Cliff Notes version of this because I know I'm going quite long, but I'm going to talk about, I had 4 chapters in my dissertation, and 2 of them are really mirroring each other with walking and running. So we're going to kind of just compare and contrast some of the differences that we found. So for walking, basically we wanted to see, are there any biomechanical loading alterations that persist long-term that might explain this increased risk of PTOA? The hypotheses for this study was that we think that the ACL limbs will still demonstrate persistent knee underloading. So decreased knee loading values between the matched and the contra limbs. So again, I'm talking about compared to a healthy control and compared to their healthy limb. And then we're going to use higher order variables to see if we can tease out any of the nuances of knee underloading. So what we did, I kind of went over the methods already. So the only thing kind of reiterating that we looked at the integral of these curves to find what we call impulse, which is the total exposure to knee forces. And we did this a standardized method of taking the integral and using the trapezoid rule. Okay, let's get into the meat of it now. So finally, the results. What was super interesting was that we found no differences in peak moments. So again, if you look back to the graph, that's the highest point. If you compare that, no differences. That actually kind of makes sense. I would hope that they're walking pretty normally at 8 years post-op. But if we stop there, we would conclude that they're fine. They're not underloading. So that's where we had to dive in a little bit more into the stats and the variables. And this is where it gets interesting. Cam impulse is the frontal plane force on your knee. This is a variable of great interest with walking mechanics, especially with osteoarthritis. We found that they were underloading when it came to cam impulse. I won't go too in depth, but basically it's a bimodal hump. So I broke this up into the first stage, the second half of stats, and total stats. What we saw was that there were trends of underloading in all three phases and throughout stats. So between ACL and healthy control subject, ACL and healthy limb, ACL and contra, decreased first cam impulse on the ACL limb. Cam impulse across stats, decrease on the ACL limb. Second cam impulse, there was actually a sex interaction, so that we found that what was driving that was the males. The ACL males had a lower cam impulse than matched healthy control males, which was not seen in the female population. But altogether, this shows that if we look at a variable that represents exposure to these forces, there is underloading that persists. Another interesting finding was this peak knee internal rotation moment. And this is a whole different discussion, but what was found previously in ACL deficient subjects was that they had this pivot shift avoidance gait when they're pushing off that last bit of push off during stats. And what they don't want to do, because their knee is unstable when they don't have an ACL, they don't like to have this internal rotation force on their knee. Our ACLs are all reconstructed, but what's interesting is that the ACL leg compared to the healthy leg, they still exhibited this exact same pivot shift avoidance gait, which tells me there's some type of somatosensory, it's probable or plausible that there's an influence there, because you cannot tell me that we can strength train someone to decrease this pivot shift avoidance gait. It's so subtle. It's something that's higher order that's being modulated by. In conjunction with that, we saw because they didn't have that normal force, they also decreased the push off with their ankle. And that could be also because they're underloading their knee. They kind of propagate or can't propagate that force through the ankle joint as well. So they have this decreased triplanar ankle moment. I want to re-emphasize that these are very small. It's not like you can see this with your naked eye, but it's still meaningful and statistically significant when we run you through a biomechanics analysis. Okay. What was interesting, minimal differences between the ACL and matched limb. I won't go over all of these. These were just kind of telling us that it's probably an altered subtle strategy, but also maybe the task is not intense enough. That's why we're not seeing differences between an ACL subject and a healthy control subject. And lastly, because we ran the contra limbs, we saw that there were minimal differences still yet. But what was interesting is that there was this, with SPM or that waveform analysis, we saw a phase difference where that they were trying to slow down their hip extension, which again, it's not a force or anything, it's just velocity. But maybe they're trying to slow down their forward momentum to kind of land softer with their other leg. But these are things that have to be further investigated, because who knows which is coming first? Is it that their hip is preventing or proactively underloading their knee? Or is it because they know that they don't want to load their knee, that their hip is slowing down? We don't know which one is driving which, but it's interesting that there might be an influence of the healthy leg in knee underloading on the ACL limb. So conclusion, what we see here is that we wouldn't have found anything meaningful with traditional discrete variables, and that could lead you into the false conclusion that there is no underloading. But in fact, when you dug a little deeper, underloading did persist in a simple task like walking. And we saw this with decreased cam impulse. We saw this pivot shift avoidance gait, which again, that's surprising because we shouldn't see those types of alterations in this population, especially when they're high functioning. And we also saw subtle differences between the ACL person and the healthy control person. You're going to see me tack this on to every single conclusion, so I'll just talk about it now. Again, to re-emphasize, I don't think this is largely due to a strength deficit or a mechanical instability deficit at this stage in the timeline post-op. So it might be more, again, sensory motor and all of those deficits that I've talked about before. Okay, so the next step is, well, let's look even deeper. Let's go even higher order variables. So this purpose was to look at sagittal plane joint work. We looked at sagittal plane because it's the simplest way to analyze joint work. Majority of our sagittal plane or movement happens in the sagittal plane. So we looked at joint work across stance phase during walking. What we see here is that our hypotheses were that ACLs would demonstrate decreased knee power and decreased knee work compared to matched and contra limbs. And again, we'll see alterations in the amount each joint is contributing to total leg work. This is just kind of getting into the nitty-gritty. Again, it's the same method to calculate cam impulse. It's just that we're using work to calculate, or we're using power to calculate the integral to designate work, joint work. This is how we calculated joint work across stance, is that we have total positive work and total negative work, and we add those two up together, and then we get a value for total joint work. And then for joint work contribution, we calculated the total leg work and took a percentage of what each joint was doing it relative to total leg work. So just to give a picture, because it gets a little confusing, this is a typical knee power graph for walking. What we're doing is that everything that's below 0, that is representative of negative joint work. And that's, in layman's terms, that's basically like, you can think of eccentric muscle or joint work is the negative value. Anything that's above 0, that's positive joint work. So that's concentric muscle or joint activity. And basically we're adding that up to, again, see what are you doing throughout the entire stance phase. So this is a little bit more complex variable for many reasons, but it gives us a better insight as to how much work they're doing across stance. So going through the results. So there was no notable group and sex interactions. I know this table is a little small. Overall, we saw decreased work in the ACL limb when compared to their healthy limb. We didn't see a lot of differences. They were trending, meaning p-value was less than 0.1, but we didn't see significant differences between ACL and healthy control for knee work. So again, maybe the task is not as intense as we would like it to tease out some of these loading differences. What we did see as a result of the lower knee work was that we saw that because knee work contribution, they were doing less at the knee, their hip work contribution had to make up for that. So we saw a compensatory mechanism of increased hip work contribution. And what's even more interesting that's related to the previous chapter, we saw this is sagittal plane hip power. We saw that there was a decrease in hip absorptive power for the healthy leg on the ACL person. And what we kind of made sense of this is that, again, maybe the healthy limb is trying to assist or take off some of the load of your ACL limb, because this happens kind of right before you heel strike on the ACL side. And the best way that we could explain this was, I had to Google this, but there's this thing called a flare technique for like airplanes and parachuters so that they don't slam into the ground. They kind of like make their landing softer. They kind of like have a soft touchdown. And we think that could be what's happening as demonstrated here with this decreased hip power on the contralateral limb. So again, it's just these subtle things that they're meaningful and significant, but why is this happening, right? So to sum up, ACL limb demonstrated decreased knee work throughout stance, compensatory increase in hip work contribution. Again, it shows that there's still underloading that persists in our sample, and potentially it's driven by the somatosensory deficits. Okay, so the next logical step is like, well, we found some meaningful things, but I bet you if we increase the task intensity, we're gonna find more things. So that's the next step, is to look at running, and we're gonna kind of mirror what we did with the walking questions and the chapters. So purpose statement to do the same thing for running. So hypotheses was that ACL limbs will still demonstrate decreased knee loading compared to match and contra limbs. And just like with the walking, we're gonna look at higher level variables. Same as walking, so I won't go into this. All right, what's interesting is for this chapter, we actually found a lot of other things that one of our master students are gonna present about some of the interactions. For this chapter, no group or sex interactions were discussed with the variables that I talk about here. What we found was that the ACL limb demonstrated lower peak KFM. So now we're actually getting a lower discrete variable output and also the exposure to knee flexion moment. So lower KFM impulse as well. And now we're not only seeing this difference between limbs, we're seeing this difference between an ACL person and a healthy control person. So level of task increase, we're seeing more obvious signs of underloading. Again, these knee underloading persists long term. What we also saw was that between an ACL and a healthy person, basically the ACL increased how much forces or moments they were experiencing at the hip. And that kind of makes sense. You got to make up for it someplace so that you can run what seems to be relatively normal. When we looked at an ACL when we looked at the contralateral limb, we saw some deficits again, and it supported and was amplified to what we saw in walking. So we saw this decrease in hip extension velocity, we saw an increase in hip extension velocity. And this was super interesting because it kind of contrasts the tasks. When you're walking, because we have both feet on the ground at the same time, the way to assist this leg is to slow down our momentum so that we can actually kind of land gently. In running, it's the opposite. We don't have 2 feet on the ground. Think of it like giving a boost. If I go slower, this leg is going to have to load and push off harder because, again, it has to create more force generation. But if I kind of speed up just ever so slightly, I can use this leg kind of as a stiff leg and a strut, which agrees with some of the literature out there that I don't have to do as much or experience as much loading on my knee. So basically what happens is that they use the opposite hip to kind of give you a little boost so that you can just have a stiff knee and kind of push through your ACL limb, and that coincides with the whole premise of underloading. Okay, and then we saw even more distinct differences between the ACL side and their contralateral limb. So these are the 2 limbs of the ACL person. And what's interesting was that we saw power differences between the limbs, where we saw more force differences between an ACL person and a healthy control person. Okay, these things, it's all in the document, so I'm not going to go in depth into this. But again, it's suggesting that stiffened knee strategy, it coincides with other literature and also would make sense why we're seeing some of this underloading that we're seeing in our ACL knee. All right, so the conclusion is higher intensity task, more discrete variable differences, and more amplified differences too. And again, supporting that they are underloading even with running. Okay, we're almost there. More differences in hip forces between ACL and healthy control person, and more differences in power between ACL and matched or the contralateral limb. All right, let's fast forward to the last chapter, running work. So we did the same thing. We're going to invest running, a higher intensity activity with more intense variables or more higher order variables. So just like mirroring the walking work chapter, we thought that you're going to see underloading characteristics in the ACL limb. All right, so hypotheses. ACL limb will demonstrate decreased knee power and work, and then we'll also see alterations in joint work contribution. Okay, same thing like the walking chapter, so I won't go into this. Let's jump to results. Okay, so we did see some group and sex interactions, specifically with sagittal knee absorptive power and total negative knee work. And we saw that females were driving this, where females were not absorbing as much power and not doing as much negative knee work relative to their healthy control counterparts, and this trend was not seen in males. So it's something to think about as to why are they doing this, which in a couple weeks from now, the master's student will cover in her thesis. Okay. Oh, this is a good example of the SPM analysis. So when we compared the actual waveforms, where that shaded region is, this showed us that there was a difference here between the female ACL and the female control. And the female ACL shows trends of doing less absorptive knee power in this graph. So again, it gives us a little bit more insight. There's a little phase there that is different, and we have to unpack that a little bit and interpret why is this happening. So let's jump to the group and sex interactions that I mentioned before. On the contra leg, we saw an interaction with total positive ankle work. And this one, both of the pairwise when we looked at the post-hoc analysis, there were no significant differences within males and within females, but both of them were trending in opposite directions, which is what drove this interaction. So again, not a huge deal, I guess, when it comes to knee loading, but it's interesting that they are doing different things across genders. Okay, I know this is small, but if you just look on the p-value column, everything in here is bold as opposed to the walking, where things were kind of trending but not really statistically significant yet. So increased intensity, we saw it's flat, it's point blank, they are underloading knee positive work, knee negative work, and total knee work compared to their healthy control counterpart and compared to their contralateral limb. And that again is significant because talking about all of the long-term adverse effects, this is something that becomes problematic over decades. So to sum it up, ACL versus matched, what I kind of mentioned, we saw decreases in knee work. As a result of the decrease in knee work, we saw an increase in ankle work contribution, and this is just due to the nature of the task. In walking, you make up for it with the hip. In running, because it's more of a spring-like kind of bounding task, we make up for it more at the ankle. You don't actually do too much in the sagittal plane with your hip when it comes to relative to your ankle. So these results made sense. ACL versus the contra limb, so their healthy limb, right? We saw the same patterns, just bigger significant values. So meaning that the p-values were more significant, the effect sizes were stronger. So we just saw a bigger degree of decreasing knee work compared to their contralateral limb. This was kind of interesting for leg work. Nothing was significantly different, but qualitatively, the ACL limb was trending lower than the healthy controls match limb, and then the contra limb was trending lower. I just realized I wrote the wrong thing on the board. The contra limb was trending higher than the contra matched limb. Now, why this is important is because we're always looking for statistically significant things, but if things are going in the opposite direction, that is why when we compare the two limbs of the ACL person, we get this huge discrepancy. Basically, in layman's terms, one leg, their healthy leg is doing slightly more than normal, their ACL limb is doing slightly less than normal. So when you compare the two, this is not normal. You have a big discrepancy between your ACL side and your contra leg. So just something to keep in mind to further tease out why we found what we found. Okay, I'm almost done. I'm almost wrapping up. So conclusion, ACL limbs demonstrated decreased knee work throughout stance, and they had a compensatory increase in ankle work contribution. Again, this supports this whole theoretical model that underloading is persisting long term. And again, these things, it's most likely driven, or there's an influence of somatosensory deficits that we need to address. So what I do want to talk about, just a few more minutes to close out this. So further considerations, like Dr. Stickley mentioned at the beginning, there's so much data that we didn't even analyze or look at yet. And to show you here, I talked about unilateral ACLs and healthy control subjects. We also have a subgroup that wasn't included in this dissertation with bilateral ACL subjects, because now it's really interesting if the ACL side is underloading. What is someone doing when they had both bilateral ACLs? Both knees were reconstructed. I don't know. There's not too much literature out there with that type of group. The second thing is we didn't even touch the strobe conditions yet, which will add a whole nother dimension to what might be happening when they have disrupted sensory input even further. And again, our tasks. We did not talk about stair negotiation, but that is something of interest too. And there's also other ways that we can look at some of this data in even walking and running. So what I wanted to close out with is some clinical key points here. And I think this has always been my interest throughout my career, and even more so now. The ACL is much more than a mechanical restraint. And I think that's something that we can spread awareness on, that we should look at it as a neurosensory organ. We should look at it as a very intricate piece to make sure that your knee is moving normally. For interventions and stuff, I know I didn't talk about this, and this isn't part of my dissertation, but I've always been interested in targeting somatosensory dysfunction and how can we mitigate both the short-term and long-term effects of, whether that's return to sport, movements, or even just abnormal loading with daily activities of living, like walking and running. there is a lot of growing evidence that demonstrates long-term underloading. So you can't see this again with your naked eye, but you have to assume that it's present. You have to assume that all of this dysfunction, more often than not, is probably there. And even if it's not there and you address it like there's a somatosensory issue, then that's probably helping the athlete or the patient as well. And the number one goal, especially through my career and with this project, is to just educate and increase awareness about PTOA and all of this type of somatosensory influence that comes with it. I want to end off with a small quote. So I thought this was very fitting. It's an Albert Einstein quote, but it just says, "We can't solve problems by using the same kind of thinking we used when we created them." And if you think about that, we got a lot of athletes to return to play. We got a lot of function restored when we looked at it as a mechanical stability problem. But the problems that we're seeing now, if we still attack it like a mechanical stability and strength problem, I don't think we'll ever make any headway with improving some of these long-term consequences of PTOA. So that's where people like Dr. Dustin Grooms with his lab and his work, neuroscience literature, and even some of the things that we're doing here, I think it shows that we have to attack this problem in a different way, and understanding the complexity of neuroscience and all of this other somatosensory influences that will help to mitigate this problem. And hopefully down the line, we don't see as many people suffering from PTOA after ACL injuries. So I know that was a lot. I feel like I've been talking way too long. Thanks for not booting me off, but thank you for listening, and I'll open it up to questions.
Thanks, Andrew.
References.
All right, I'm going to let Dr. Murata kick us off today with questions from the committee.
Okay. First of all, Andrew, nice job. It's been a long time since you and I had that first conversation years ago. So good to see you at this stage. And thank you to your advisor for creating a 200-page dissertation. It was fun reading. Thank you. Thank you. Question with regard to subjects. 37 subjects. Some people, male, females. Males, females, 27. 23. Males, 14. Is that correct?
Yes.
So a total of 37.
Total of 37.
So essentially what you've done is taken those exact same subjects. First of all, how were they recruited? Strong?
No, they were actually recruited through colleagues and just the community. Yeah.
Essentially what happened here with regard to what you presented is that in each study, your chapter, the 2 walking and the 2 running, essentially those are the same subjects, right?
Yes.
And so each that you're reporting based on that one study of walking. So by any chance, did you get an opportunity to look at within subjects?
That is, yeah, actually we're having that discussion recently, because it would be super interesting to see, do people that underload with all of these things, or do they only underload with work, or do they only underload with walking? That is another analysis that we want to do.
I put that on the chart.
Yeah. More things to do, yeah.
We actually, your name came up because I said, when you do that, we'll need some help because you do single subject analysis, different statistical models. We're like, we need Dr. Murata to help us do that.
Well, I mean, I think that would be interesting with regard, because you're talking long term.
Yes.
So in long term research, wouldn't you want to follow so whether it's either subject or participant?
Yeah.
But follow that participant for more months. So might be something to consider when you add that another column to your list. Maybe another master's student take on that. So that was probably one of my bigger questions. The findings are fine. And the other general question that I have is, our equipment has been around for a long time. I know that. So how is the, I didn't hear anything explain or cover anything about the calibration of any of the instrumentation.
That's true, yeah.
So what's happening?
Yeah, so we calibrated it how we've always been doing, the same protocol. So calibrating our motion capture system, calibrating the force plate. As far as like maintenance calibration, I'm deferring to him because he said that, oh, it's calibrated, yeah. So we haven't done that during my time here, but I think it was done before I got here, soon before.
Do you think if it's on the publication where they want, like,
Yes, yep. We definitely will include that in the methods.
and you can also see the chair on the paying for more money to get calibrated.
Yeah, yeah.
Highly used for all the students.
Yes. Yes.
That's just all my thoughts.
No, thank you.
And thank you for your work. That's always good advice from master students.
Scott.
Thanks. Andrew's really good presentation. It was a really good read. One of the challenges I've always had with this is number one, a really complex system. Number two, though, is the jargon that's used, and talk about QA, about tibial slope, and it's like, what is all this stuff? So you did a really nice job explaining your variables, and I appreciate that. So let me just kind of start from like the 30,000 foot level. ACL. If an ACL could talk, and you ask the question, what's your purpose in life? What would be the response?
That's a good question. I'm going to repeat it for the guys on Zoom. So Dr. Lozanoff asked, basically, if the ACL could talk and what is its purpose in life, what would the ACL's response be?
Point out that Dr. Lozanoff is the Emeritus Chair of Anatomy for 20 years, so it's an appropriate question to someone.
He was the chair, he was the longtime chair of the anatomy department. So this is a very good question. And no, I appreciate this because it makes me think too. I think in general, the number one function of the ACL, again, I go to that dental example. I think what it's really there to detect is the arthrokinematics in the joint. Specifically, I think screw hole mechanism, where I was kind of surprised with all of this research out there, because I think the thing that we forget is it's not only tension and rate of tension and all of this stuff, but the ACL, I think when you have your native ACL there, it actually acts as a chiasm to wind around your PCL when we start to go into those dangerous ranges, or I shouldn't say dangerous ranges, the ranges that the ACL gets stretched or tensioned the most. So that kind of maybe anywhere from like 0 to 60-degree arc. And I think the ACL's role is to kind of really communicate the subtle motion to your brain, and you can coordinate all of your muscles that control that intricate rotation, the frontal plane movement, right? Flexion and extension is primarily what we think, but I think it's all of the other subtle movements that's super critical for normal knee function and loading, and of course performance as well, right? So I think that's what the ACL's role is your job is to detect arthrokinematic changes, not so much like the big gross movements, because I think other muscles like your quads, all of the big prime movers can detect those better, but nothing can detect the subtle kind of arthrokinematic movements. So that would be my guess.
So what muscle groups does it most appreciate, and why would you say?
That's a good question. Well, I think the big thing, so the question was, what muscle groups does it most appreciate? What's interesting is that, because when we talk about
receptor, that'd be a lot of communication.
I think what it takes me back to is like, in my literature review, there's that section on sensory integration, and there's people on this call that can probably answer this way better than I can. But sensory integration is super interesting because we're constantly getting like, I don't know, billions of sensory information with every step that we take. And what I think is that, I don't know if it's the actual muscles that cross the knee joint that would help out the ACL. I think it's more the hip muscles, the ankle muscles, and some of those things. So when we take that signal from the ACL and we integrate it with everything else, touch, feel, pressure, visual input and all of that, I think what the ACL is doing is it's relaying important information. My guess is from the hip and the ankle and other places that are outside of that local environment of the knee joint. And I think that might be those muscles that kind of appreciate the information from the ACL. So it's kind of this kinetic chain approach, not so much like, I don't know if your quad is going to do that much to, control like screw home mechanism, right? But all of these other muscles are going to play a big part in that fine-tuned movement, right? So it's hard to say, I don't know the right answer, but that's kind of the approach that I kind of take this.
In terms of male-female differences, though, it's a lot of emphasis is placed on the quads, right?
Yeah.
So that's going to be running across the knee joint. So do you think there's a preference there?
Possibly. I also do think when we talk about females and some of the anatomical differences and things like that, it definitely does influence like ACL loading and knee loading mechanics and stuff like that. But again, I think that's just one part that has been heavily emphasized or focused on in literature because of, and it could be because of ease of research or ease of, it's the most obvious or low-hanging fruit. But when it comes to some of this somatosensory function, it's really hard to say if that's like one of the big factors because again, there's so much things that our sensory motor system is trying to integrate together, more so than just controlling range of motion or force development. Yeah.
So in an ACL graft, how's that going to affect that somatosensory relationship?
That's good, because I skipped over that part, I realized, in the presentation. But what happens is that when your ACL is damaged, that peripheral deafferentation is what they call it. All of those sensory organs or sensory receptors in your ACL, they lost function. So because the ACL is damaged, even like a repair, it's very debatable if you're going to ever get those sensory connections back. So it's really the fact that you don't have your native ACL. Again, surgery is not going to restore those sensory connections back. So that is what's kind of driving all of these proposed deficits, because we don't have, or we can't figure out how to restore that neurosensory function or connections once you injured your ACL.
So have there been studies on which nerves conduct those sensory? And are there bigger effects like deficits, in the femoral versus sciatic?
That's true. I don't know of many, but again, I could be wrong. What I do know is that emerging research is getting better at testing some of this. I don't know if it's at the actual, cellular level to see like conduction and all of that kind of stuff. But as far as like monitoring outputs, right? Like whether that's joint position sense or discrimination studies or, all of these kind of things, that they're kind of inferring that, okay, this is what's happening with your afferent signals. As far as actual nerve studies and neuroscience studies, I haven't come across too many. But again, I don't think I was looking or focusing on that too much, but that would be super interesting because what else can send similar signals around that area, right? And maybe we need to focus on targeting those with intervention strategies and whatnot to restore some of this neurosensory function. Yeah.
Okay, thank you.
Okay. So kind of piggybacking on that model, you mentioned that if ACL can talk, then my job is my job is to send signal to the brain. And you said that the contributors or ankles and hips are more appreciated.
Muscles, I think are appreciating the feedback, right? But
so if that's true, I want you to kind of clarify that framework or model. Then what happens if you don't have ACL? What happens to the ankles and hip muscles? How would they react?
Well, I think so the question was, if we don't have an ACL, then how would the ankle and hip muscles react or respond to that? I think the big missing part is that basically we have lack of information from our knee joint to our brain. And the things that are trying to make up for it, they're probably not as equipped or not as heightened to send proper information. I kind of relate it to if you know someone that's like hearing or visually impaired, right? In the beginning, until they learn how to heighten their other senses, right? Whether that's like going through intervention or by themselves, they don't really know what's the best or most efficient way to carry out a task, right? So I'm kind of taking that same model. So if like we don't have the correct information being sent up to our brain, basically our brain is finding alternate ways to make up for that lack of sense or feedback, and then it's creating abnormal kind of like motor outputs because it's taking its best guess at that point as to like maybe what you experienced in the previous history of walking or running or whatever it is. So I don't know if it's that those muscles will actually adapt more so than the adaptation is happening in your brain. Your brain is now altered and sending this different signal because it's missing information from your ACL or your knee. So I think it's more like that. So that's why I would suggest that what appreciates kind of the ACL signal the most would be kind of globally all of those muscles that are used to firing at this certain rate, creating stiffness, creating coordination and all of that. Those muscles probably get the most effective when you don't have your normal ACL. And then to take it a step further, right, the motor output of actually loading your knee, that is altered, or that is, underloading now. And that is where the knee, I think that's where the model fits. But the reason of why the knee is underloading, I think it's the change in the brain that they've kind of shown with some emerging neuroscience research.
Yeah, so I guess a lot of my comments, I don't have to describe it here, but in one manuscript, there's a lot of information and it goes kind of all over the place. And it could be hard to follow. So the reason why I asked that is because some of the paper, you include all of the joints, and maybe the theoretical framework is slightly different for each of the variables. So if you can have a separate theoretical framework for what happens with the ankle, what happens with the hip, then maybe that could be a standalone paper.
That's true.
Focusing on other joints versus tacking them into like knee loading, knee focused paper. My other question is, with the ACL subjects or participants, it's very possible that their static alignment is different bilaterally due to the knee laxity. Have you checked the static alignment? And if there is a bilateral difference, let's just say, the ACL injured tibia is already internally rotated or hyperextended, how would that affect the biomechanical variable and different doses?
That is a super good question. And along those lines, so we did not test, for joint alignment. I mean, we have our calibration trial, which, that would be interesting to find. We didn't test for strength either, right? All of these things were kind of making some assumptions, I guess you can say, within reason, right? The joint alignment thing is interesting because if you look at our calibration trials, so for this study, I markered up every single subject. I feel that I've gotten really consistent with putting it on the landmarks that I think should be defining the knee joint center. What's super interesting is they came for 2 sessions. So the first session we did walking and stairs. Second session they did running because we had to run in shoes and we had to make it more like, reasonable chunks of time. So I did 2 calibration trials. A lot of the ACL knees, I looked at their knee mark and I'm like, that looks crooked, it looks, for lack of a better term, it looks off. But when you look at my 2 different sessions that I calibrated them, it's pretty spot on. So there were definite alignment issues, I think, in some of these ACL subjects with internal rotation, frontal plane mechanics, which would be super interesting to write a study or a manuscript about that, right? Because how does their static alignment transfer to the dynamic tasks? Because again, we don't know, and I don't think I've come across anything like that either.
Would that actually affect alteration? Like, because joint center is calculated based on the static trial, right? And if that is already off, and then if the tibia further internally rotate, or it's already in the internally rotated position, then would that affect the further calculation?
the short answer is it probably does affect, but is it meaningful, right? And that, again, it's really interesting to see because, for those of you that don't know biomechanics research, right, there's so many things there's so much room for error. There's so many things that can go wrong, and you calculate things a certain way. It does change sometimes the results or the conclusions that you can make. So again, that's something of interest too that I think we'll definitely do, because there's a lot of methodological questions that I have with the procedures, and does this actually make a meaningful change or does it not make a difference? So yeah, those are all really interesting things that we want to look at. Yeah.
Phenomenal. I remember we sat down for lunch into the meeting 3 years ago. I told you we'd be here to help you, but it was up to you to stay the ship. And which I see it's exceeded expectations. So congratulations. You added in from the proposal, we talked a little bit about graft selection. But from this group, somehow enrolled a femur bone bruise, meniscus. How do you think that might play into the PTO?
Definitely, I think there's so many factors, right, that we're trying to control for in this study as best as we can. But I do think all of those things definitely contribute to PTOA, right? To the point where, like, at the time of study, I was pretty adamant about asking all of them, like, how does your knee feel? Because, you could even go out for a run one day, an extra long run or something, and be like, oh, my knee's a little achy, right? I made sure that we tried to schedule them under normal conditions. Was I super strict, like giving them a full knee eval before they came in? No, but then I also tried to make sure that we control for that. But that's correct, because I know some of these, especially the patients that I've worked with personally over the years, I know there's been times where, like, oh, whatever your activity is, like you had tendonitis for like a couple months, or you had like, minor effusion for a few months because you did something in your activity, right? So I made sure that wasn't when they were participating in the study. But again, if you periodically have that every year, right, does that accelerate your chances of PTOA? I would guess probably, but we don't know for sure, right? Because I think more longitudinal studies are needed, right, to kind of track all of these incidences of what they're going through with knee health, loading, and all of this stuff. But I think it probably does play a difference.
Washed out amongst the participants, or
I think this kind of goes, so the question was like, do I think that all like meniscus repairs, meniscectomies, and all of that kind of washed off among participants and didn't affect the results too much? And I think this kind of goes with Dr. Murata's question too, because ideally I wanted to have equal males and females. It was really hard to get males because a lot of the males that I contacted, they either had one thing that excluded them from the study, or they had another surgery on another joint, or they had a significant injury, that was like, that doesn't really put you in the isolated ACL category. So again, why I say this is because meniscectomies and all of that, research has shown that if you have, more and more of your meniscus removed, then your rates of PTOA is going up. With every single portion of meniscus removed. Meniscus repairs are still thought to be a little bit more helping to save your knee joint and mitigate some of the PTOA risks. So we know that the more meniscus that you have removed, the worse off your chances are. Your path looks a little bit more dark. As far as the sample size, even though I didn't get more males, even though I didn't really exclude meniscectomies and stuff like that, unless it was done at a separate incident than the ACL injury or surgery. If it was done with the ACL surgery, I took all of them. And what I think, looking through it, I think even though the numbers are kind of, not all over the place, for lack of a better term, I think it's very representative of what the actual population of ACL injuries look like. Majority of them had some partial meniscectomy. I think it's written in a manuscript, I had 7 meniscal repairs. I think that's kind of what you saw. I had some reported ALL ligament repairs or reconstruction. I had, other people that, I I forget, the graphs were a pretty good distribution. Males and females, again, I think that's pretty representative of, we know that females sustain more ACL injuries, so that kind of 66% females and 33% males, I actually think it worked out to what the actual sample or what the real population of ACL injuries look like out there. So I don't know if it helped or hurt the results, but overall I would say that I think that is pretty representative of what we would find if we even had a larger sample size.
During the run, found more hip differences. Talk to me about pelvis.
What about the pelvis?
What do you think is going on there, right? Because if we're running, this all stands, the femurs relatively in stationary position.
Yep.
So if we see changes in the hip area, we have to consider the pelvis component.
Mm-hmm. I think the first thing that comes to mind, so the question was in my running chapters, a lot of hip differences and what's the pelvis involvement of that, because the femur is relatively stable and the pelvis is moving on the femur, especially during stance in that closed chain kind of activity. So I think what's happening is that just like when we see with osteoarthritis, maybe this is more of an extreme example, but they're probably doing something with either center of mass or foot pressure or something to assist the knee underloading. And yes, you have simply think of gross movements like Trendelenburg or, the hip drop and, all of this kind of things. But these are so subtle that for some reason, they just don't want to absorb force on that ACL knee. So by shifting your weight over a little bit or having more somewhere like adduction velocities, a lot of adduction and internal rotation moments, right? That's when we land. Having higher forces there, I think it's setting themselves up so that I can pick up some of the slack in my hip so that my knee doesn't have to withstand that normal load. And again, I don't think it's because the knee is not capable of withstanding those loads. I think it's that sensory input. Like the knee is just unsure of what do I need to do, even at 8 years post-op, right? So then they create this compensatory pattern that you can't detect with your naked eye. But again, they're compensating in these slight ways from higher order kind of processing centers. Oh no, actually I didn't. Probably I would say maybe 15, maybe a third of the sample. Yeah. But I knew more of them, but I didn't, because a lot of the people that I reached out to, they had, either other injuries or other surgeries, yeah.
Yeah. So now that you take a picture, you have all this information about what are you doing in a clinical approach to the ACL evaluation and treatment.
I think I was fortunate to have kind of this somatosensory kind of ideal or influence, even when I was practicing long ago. I don't know if I would actually change anything, but I think I'm interested in learning more about what is going to work, what actual anecdotally and literature will show with how do we actually mitigate this sensory motor function. And there's a lot of things that I've done, and Dr. Dustin Grooms, he's put out a lot of things like motor learning strategies or using the strobe glasses, and I tend to apply all of those to clinical practices. But if you were to ask me, how do I make someone, if I were to train someone for 6 months and how do I get their knee moment to be normal, I'm not sure if I have ideas of what may work to give them the tools to do so, but I don't know what will definitively show oh, this is how we mitigate some of these issues, right? And I think that's what's interesting. In the next 5 or 10 years, it would be really interesting to know what neuroscience research has uncovered and what we know to be effective to kind of restore all of this. Because for everyone here, right, on Zoom too, if I started off with ACL people can't even walk normally 8 years post-op, you would have been like, yeah, right, But I mean, it's actually true. They're not limping, but they're still not walking normally. Yeah. I know. We can keep going for a long time.
Over the last few months, I've asked Andrew every single question I probably could have possibly asked, so let me just use a minute to say a couple thank yous. Obviously, this committee is super helpful to me throughout my career and has been to Andrew. I also want to say thanks. Andrew has mentioned several times Dr. Dustin Grooms, who is actually one of the national and international leaders in this type of research. And his name came up, and I said to Andrew early on, you know what? Dustin Grooms was an undergraduate at Northern Kentucky University athletic training program when I was the head athletic trainer at NKU. So I know this guy. So we called him up, and here he is. He's a world-renowned researcher in this area. And I just said, hey, remember me? You had me for care and prevention of athletic injuries way back when. Would you mind hopping on a call with my PhD student and talking about it? And he was like, sure. And that level of collaboration out of the blue was very appreciated. And then he was on this call and came and listened to this. He had to sign off a few minutes ago, but I appreciate him being here. The other one is Dr. Flanagan, friend and biomechanist, colleague at Cal State Northridge, who's interacted with Andrew with some of this through poster presentations at FWADA the last few years. And he's on here today, so I appreciate him coming by and supporting and just providing feedback. He's provided, kind of just mentoring type feedback along the way as well. I'm going to cut this to 2 questions from the audience, and then the committee will retire. So if you have a burning question, get your hand up early, or else we're going to run out of time. Darian first. Darian gets a question.
Oh, there's on Zoom too.
Oh.
Dr. Flanagan and chat.
I think I got Flanagan.
Yeah.
I got Flanagan answered, I think.
Oh, I just had a follow-up if I could ask it real quick.
Yes.
Okay,
And that is, you were walking, your participants walked at a preferred speed, correct?
Wait. Who am I going first? Dr. Flanagan's asking first. Go with him first? Yeah.
What did he ask?
No, he's asking now. Go ahead, Dr. Flanagan.
Oh, he has an actual question. Okay, Go ahead.
Yeah, it was just a follow-up question. In terms of your participants, and they all walked at their preferred speed, correct?
Yes.
Did your ACL participants walk slower, or did you compare their gait speeds, I guess I want to ask?
Yep. So the question that he's asking is that the walking was performed at self-selected speed, and was there any difference between the ACL and control group? And we did compare it, and there was no difference. So, that kind of, because of course, walking faster or slower, especially if they walk slower, right? We might decrease some of the loading. So we made sure that there was no significant difference in the walking speed. And the running speed, they were actually super tight and really good at replicating that 4 meters per second. So, yeah. Okay. Who was the question? Darren.
Mine was quick two-parter. In your study, did you collect the type of graph each participant received and whether or not that played a confounding role in the results you got? And then also, in your opinion, do you think those who received the grafts changing the tissue structure itself from an actual ligament to a tendon played a role in the neural feedback?
That's a good question. So I think they heard it on Zoom. So yes, we, as accurately as I could, to the point where they were sending me verbatim what was on their surgical notes, we collected what graft they were used, or what graft was used. In this model, I think the thing to get away from is that if you think of it purely from the mechanical standpoint, then yeah, graft might have influence. But if you think about it from the sensory motor standpoint, then you just don't have your native ACL. Doesn't matter if I put a cadaver graft, your own graft, hamstring, patellar tendon, all of that. At this point in time, you should have recovered from that and figured out how to use that, right? The question is why do these subtle underloading things persist? If you're looking at maybe who recovers better hamstring strength or whatever after a year, then yeah, I would say definitely hamstring grafts are at a disadvantage compared to BTPs or whatever it is. But at this point in time, I don't think the graft is going to make a difference. Meaning that, and this is where the individual analysis would be super helpful, right? To look at, what grafts made a difference and maybe do run the stats in subgroupings of graft types. But overall, and other literature has reported graft types too, or tried to use a uniform sample of graft types. And I think the results, for the most part, what I've seen, it comes out the same. But it would be interesting to see. But if it doesn't change any of the results, it makes sense because we're looking at it more as a somatosensory influence, more so than a mechanical influence. And all the grafts, like hamstring graft, patellar grafts, they're all like 3 to 4 times a stronger tensile strength than your native ACL. When they do either cadaver studies or even other types of studies. So mechanical tension and your ability to heal wherever they harvested the graft from, at 8 years post-op, I think you're probably going to be as healed as you possibly can be.
At the same time, from the somatosensory point of view, the tendon has proprioceptors, the hamstring tendon has proprioceptors.
That is very true.
Take them off, then you're butchering their proprioceptors.
That is very true, yeah. And that would be interesting too, because I'm not sure, if we looked at the big picture, like the piece of the pie, right? I don't know what types of effects, damaging some of these are. Especially, I guess, hamstring tendon. That would be super interesting because that's a long tendon. So that sense, like GTOs and stuff in your hamstring tendon, that could be a significant one. Patellar tendon, yeah, you damaged it, but you still have 2/3 of it there, but I don't know what the influence is of, yeah. I just have a hard time saying that any one of them can do the same job, like, what the ACL is responsible for with the arthrokinematics of the knee. Yeah.
Okay, so in the interest of Dr. Murata's schedule, getting out of here on time, I'm going to ask committee if we can step back to biomechanics office real quick for a minute and discuss. Hey, you can leave this open and answer questions on Zoom if you like while we're on, or you can just chat with your audience. But did you prepare something to keep them entertained while?
No.
Okay.
We're going to watch YouTube. No. All right. Thanks for coming, everyone. I feel like I've been talking forever. One thing.